The Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policy Maternity Staff Training Program. Hospital Practices that Assist with Breastfeeding, Session 7. Objectives. During this session, we will cover things that you can do to support breastfeeding in the hospital. Special attention will be given to postpartum management policies and procedures that support exclusive breastfeeding. At the end of this training session, you will be able to identify 3 in-hospital strategies for early breastfeeding management. Research has shown improvement in breastfeeding initiation and duration rates when hospitals implement breastfeeding supportive practices, some of which are shown on this slide. The information we will cover is evidence-based, accepted practices that are used in hospitals around the world. Rooming in is when mothers and babies share the same room, sleep in close proximities but not in the same bed during their hospital stay. In following rooming in protocols, mothers and babies stay together 24 hours a day. Medical procedures, when possible, occur in the room. When separation is necessary for specific medical reasons, Baby Friendly recommends the separations should be no longer than 1 hour per day. Circumcisions is an example of a medical reason that might require a baby to be temporarily removed from the mother's room. Having the mother close to her baby allows her to participate in caring for her newborn. The mother can learn her baby's cues, and the two can learn how to breastfeed together. This ultimately gets breastfeeding off to a more successful start than when rooming in is not practiced. Research has identified that when mothers and babies room together, infants have improved body temperatures and better blood glucose levels. Mothers and babies get more restful sleep and babies cry less. Other research has shown that mothers who room in with babies have higher milk yields during the first 4 days after birth. Still, other research has shown that rooming in reduces the occurrence of hospital-acquired infections and jaundice. As a result, mothers and babies stay healthier, require shorter hospital stays, and healthcare costs are less compared to the costs accrued when mothers and babies do not room in. Research has shown that when babies room in with their mothers, babies are breastfed more often. By breastfeeding more often during these early days, mothers are being set up for better milk supplies and better breastfeeding success. In addition, these babies and mothers are more readily learning the skills of breastfeeding. Most hospital routines are easily done in the mother-infant room. Physicians and staff find that they save time because, while they assess or examine the baby, they can simultaneously teach and explain findings to the parents. Patient safety is of utmost concern. The nurse can easily address this by ensuring that the mother is awake and physically able to hold and move her baby. If mother is at risk to fall asleep while holding her baby, assure another adult is in the room during feedings. Encourage other loving adults to hold the baby when mom does not feel well or up to holding her infant, and demonstrate appropriate bassinet use for times when no one is holding the baby. Changing staff and patient mindset is one area that may need to be addressed. Some hospitals choose to no longer continue newborn nurseries and keep all full-term newborns in the mother's rooms. Others that continue to house a small newborn nursery may consider making some changes, such as renaming the nursery to the Neonatal Observation Unit and/or turning down the lights so the area does not seem quite as inviting. Finally, placing equipment needed for bedside routines on portable trolleys allows staff to easily and efficiently move from room to room to perform their daily tasks while minimizing hospital equipment costs. Baby-led feeding is simply allowing the baby to determine when and how long to feed. This is only feasible when there is 24-hour rooming in, since mothers need to respond to their infant's early feeding cues. If the infant is in the nursery, feeding cues are often missed or response to them is delayed, resulting in missed opportunities to breastfeed and a delay in mother's milk production. The baby also needs to be able to end the feeding rather than being removed from the breast after a set amount of time. Allowing a baby to end the feeding indicates that the baby is satiated. Finally, feedings are often irregularly spaced. It is not unusual for a breastfed baby to feed frequently for several feedings in a row, which we refer to as cluster feeding. Feeding sessions typically last for 15 to 20 minutes when infants are older than 4 days. Longer feedings should be allowed, if desired by the baby, although they might be an indication of low milk supply or inadequate milk transfer. Thus, the breastfeeding couplet should be monitored closely, as additional interventions may be helpful. Facilitate the baby taking the lead within the first hour of birth by placing the naked baby immediately after birth on the mother's bare chest. The infant has been sucking its fingers and hands while in the uterus, tasting the amniotic fluid. The familiar taste and smell is now on the mother's chest and helping the infant to initiate breastfeeding. Research has shown that infants can also smell and recognize their own mother's milk. Placing the infant skin to skin and allowing him to self-attach helps with both initiating breastfeeding and thermoregulation of the newborn. Mothers need to be alert to the cues of their infants. When the baby is awake and looking around, this is an ideal time to have the mother put the baby to breast. Teach mothers to offer the breast when their babies are alert, moving their arms and legs, opening and closing their mouths, and/or sucking on their fingers or hands. Crying is a late sign of wanting to feed. If a mother waits until the baby is crying or until a certain amount of time has elapsed since the last feeding, infants become disorganized and more difficult to latch than when in a calmer state. Mothers should be guided to watch the baby, not the clock, and taught to recognize feeding cues. The infant should be the one to end the feeding. This indicates he is satisfied. Babies allowed to feed on demand have earlier passage of meconium. Their frequent feeding desire facilitates breast milk flowing sooner and larger volumes of milk intake by day 3. This in turn results in less overall weight loss since delivery and lower incidence of jaundice. Research has shown that infants allowed to decide when and how much to feed have longer durations of breastfeeding and are more likely to be fed exclusively on breast milk. Just the presence of the baby on her mother's bare chest, licking and moving around, stimulates the release of maternal oxytocin. This oxytocin release is significant in stimulating uterine contractions, in turn decreasing bleeding after delivery, while also being responsible for milk ejection, commonly known as letdown, and maternal-infant bonding. Research studies have shown a greater milk volume in mothers who held their babies skin-to-skin frequently during the hospital stay. In a randomized study of 30 newborns, skin-to-skin contact showed to be a remarkable intervention against the pain experienced during heel sticks. One group of infants was held skin-to-skin with their mother, while the other group was swaddled in the crib for the procedure. The studies compared crying, grimacing, and heart rate differences. The results showed that the group of babies held skin-to-skin cried 82% less, with 65% less grimacing, compared with the controlled group. Heart rates showed a substantial reduction in the skin-to-skin group. The infants were held skin-to-skin for 15 minutes before the heel stick was performed. T. Barry Brazelton classified 6 different infant behavior states. The more active a baby becomes, the more difficult it will be to correctly latch the baby at the breast. A crying baby is too disorganized and upset to correctly latch, and an infant in a deep sleep state will not wake up at all to feed. The best time to initiate breastfeeding is when the baby first starts to wake up. This stage is known as the quiet, semi-awake state. Teaching parents normal newborn behavior helps to prepare them to properly care for their babies. Understanding that babies should normally wake and feed frequently in order to maintain their needs to grow and to stimulate mother's milk production helps parents to recognize normal baby caretaking. Let parents know that babies, while following some basic regular patterns, wake and feed according to their own ever-changing needs and not necessarily according to a schedule. Establishing a schedule of feeding too early interferes with successful breastfeeding. Helping parents to understand the many reasons that a baby may cry will allow them to problem solve instead of immediately worrying about feeding adequacy. Showing parents techniques to wake an overly sleepy baby that needs to be aroused to feed or to help soothe a crying baby empowers them to care for their infant safely and appropriately. Labor pain medications may require some babies to need help in achieving a behavior state that facilitates effective latch. In these situations, a mother often needs to help her baby achieve a quiet, semi-awake state before putting him to the breast. If the baby is sleepy, unwrapping and changing the diaper may be all that is needed. Placing an infant skin-to-skin in an upright position with tactile stimulation on his back is one of the most effective ways to achieve this quiet, semi-awake state. The goal is to gently stimulate the baby without upsetting him. There are many reasons a baby may cry. Yes, the baby may need to feed, but that's not the only reason babies cry. Since babies can't talk, they cry to communicate their needs. Babies need to be held much more than many adults realize, and crying may simply indicate this need. Sometimes babies cry because they need a diaper changed. Other times it's because they're tired or overwhelmed. Too much noise, a cold breeze, a strong or unpleasant smell, or an odd vibration may cause a baby to cry. A baby may cry to invite interaction or indicate need to play. Sometimes there is no clear reason why baby cries. Research has shown that all too often, breastfeeding is discontinued because parents misread babies' crying cues, thinking feeding is inadequate when the cry may have nothing to do with feeding. It is therefore imperative that we teach parents to recognize what the cry means so they can attend to the needs, or simply be a calming presence for a crying baby when there is no clear reason. Sometimes a baby will cry when ill. When in doubt, parents should be advised to call the pediatrician for further guidance. The universal recommendations is that babies be fed exclusively breast milk for the first 6 months of life and continue to breastfeed for at least a year of age while consuming appropriate complementary foods beginning at 6 months. Giving babies formula or other supplementary foods unnecessarily will negatively impact breastfeeding. Mother's body responds to the baby's feeding requests, producing milk based on baby's demand and the amount removed. When formula or other foods are substituted or added to the baby's diet, the baby is more satiated and in turn demands less feedings from the mother. Feedings end up being missed or delayed, putting mother at risk for engorgement due to milk not being removed. This further suggests to the mother's body that less is needed, causing maternal milk volumes to reduce and putting the mother at risk for low milk supply. Supplemental feedings can also negatively affect the baby's ability to feed at the breast, because the way an infant sucks on the breast is very different than the way he sucks on a bottle. If he sucks on the breast in the same way he begins to suck on the bottle, mother's milk will not be effectively removed. Even just one supplement of formula places an infant at risk for developing cow's milk intolerance or allergies. This one supplement also increases the risk of diarrhea, meningitis, sepsis, and later development of type 1 diabetes. Exclusive breast milk feeding helps with gut cell membrane closure, a process of tightening of the junctions between the cells of the gut mucosa. Breast milk coats the lining of the gastrointestinal tract, aiding gut closure and protecting the body from invading microbes and whole proteins. According to the World Health Organization and UNICEF, the best supplement is mother's own expressed breast milk. When this is not available, donor human milk is the next best option. When no other adequate human milk source is available, a hypoallergenic infant formula is best, followed only by commercial cow milk-based infant formula. Acceptable medical indications for infant formula include diagnoses with galactosemia, maple syrup urine disease, or other inborn errors of metabolism. Infants who can breastfeed but may need a supplement due to a medical indication would be infants that are very low birth weight, specifically those less than 1,500 grams, premature infants less than 32 weeks gestation, infants with low blood sugars who are symptomatic and the blood sugars are unresponsive to breastfeeding, or infants of mothers that have inadequate milk supply. There are very few contraindications to breastfeeding according to the CDC. Maternal conditions would include mothers with HIV or AIDS, mothers taking antiretroviral medications, severe illness preventing a mother from caring for her infant, maternal use of dependent or illicit drugs, having active untreated tuberculosis, taking prescription anti-cancer drugs that interfere with cell replication, or mothers undergoing radiation therapy, not to be confused with diagnostic radiology like X-rays or CAT scans. When supplementation is required for the breastfed infant, one must work to introduce the supplements in a way that will least likely interfere with breastfeeding. Feeding from a bottle is significantly different than feeding at the breast. To hold a bottle nipple or pacifier, the infant must squeeze the gums together to either allow flow or to reduce flow using a tight closed mouth. At the breast, the baby has a wide open gape and uses the tongue in a wave-like motion to milk the breast. Because of this difference in the way an infant sucks on the breast versus a bottle, using bottles for feeding when breastfeeding has not been well established can interfere with breastfeeding and have a negative effect on breastfeeding success. When supplemental feedings are medically indicated and an order has been written, Alternatives to bottles will help to nurture and improve a mother's chances at successful breastfeeding while still providing the supplement to the infant. There are several options. The mother-infant dyad will determine which one works best for them. Alternative methods include using a supplemental nursing system at the breast, syringe or finger feeding, cup feeding, or using a spoon or a dropper. Always follow hospital policy and procedures when recommending methods for supplementation of a breastfed baby. The Maryland Hospital Breastfeeding Policy, in accordance with the American Academy of Pediatrics, recommends that full-term, healthy breastfed newborns not be given pacifiers during their birth hospital stay. Newborns who need to suck should be suckling at the breast, not on a pacifier. Research has shown the introduction of pacifiers before breastfeeding is well established in the first month interferes with breastfeeding success and continued breastfeeding once home from the hospital. When infants are sucking on a pacifier in the first weeks of life, research has shown a decrease in mother's milk supply and an increased risk of engorgement and sore nipples. For the infant, sucking on a pacifier this early has correlated with slower weight gain, higher risk of jaundice, increased risk of ear infections, and increased likelihood of developing thrush. The only time early pacifier use is acceptable is during a painful procedure such as a circumcision or IV insertion. Once the procedure is finished, the pacifier should be thrown away. Both Maryland breastfeeding hospital policies and the Baby-Friendly Hospital Initiative include the recommendation that hospitals not accept free formula advertisements including individual packaged bottles and nipples with formula company marketing, or formula coupons for use in the hospital or distribution to breastfeeding mothers. The idea here is for the hospital to focus on marketing health. If giving free formula or advertisements, hospitals and their staff are sending a message to patients and families that they stand behind these products and that these products are necessary. A free formula gift bag from a hospital implies to a new mother that the hospital staff endorses the product and feel the formula is needed. Research has shown that mothers who receive free formula upon discharge from the hospital are more likely to begin supplementing with formula earlier and cease breastfeeding altogether compared with mothers who did not receive formula giveaways. The Joint Commission for Hospital Accreditation is currently recommending reimbursement based on quality of care and implementation of evidence-based practices. Other practices recommended within the Maryland Hospital breastfeeding policies and baby-friendly include that storage of formula and supplies for those who are not breastfeeding be kept in a medication cart or separate storage space out of view to the patients. In this way, your hospital will not be marketing non-breast milk products and ultimately not undermine the breastfeeding couplet during their early learning process. Hospitals seeking baby-friendly certification will also need to follow the World Health Organization's International Code of Marketing of Breast Milk Substitutes. The code was developed in 1981 as a global public health strategy to ensure that women and children were not discouraged from breastfeeding or that efforts to breastfeed were not undermined by the use of formula. In addition to not advertising or marketing infant formula, hospitals seeking baby-friendly must refrain from the use of artificial feeding products, including bottles, nipples, or pacifiers with breastfed infants. The hospitals must purchase their own formula, bottles, nipples, and pacifiers in the same way that they purchase all other hospital supplies. Formula companies for years have dropped off free marketing gifts to nurses and healthcare workers, providing free food and education. Whether we realize it or not, this practice sways professional judgment, influencing all of us towards brand loyalty. Healthcare professionals should be in the practice of marketing health and providing patients with research-based information. Hospital practices are critical to the support of breastfeeding. Evidence-based changes in hospital practices improve breastfeeding rates, reduce costs, and increase quality of care.